morning difficult to comprehend. I try to take you through it. And I changed after the past few days my presentation from evidence-based versus evidence-based medicine. So we are coming from an evidence-based approach. So we see somebody standing before you saying, this is my method and this is the truth, without showing data. And I think we should all have data. So I have a lot of conflicts of interest, and yesterday I said there's no interference with my presentation, but here it is. Because I'm a neurosurgeon, but I'm also a spine surgeon. So if I talk about costs and evidence, I always want to prepare that surgery for spine diseases is beneficial. On the other hand, I also receive money from the government and insurance companies. Everybody's looking to these kinds of conflicts of interest, Medtronic, Paradigm, Brown, because it's in the misty way. It's not good to have money from industry to do a study. That's depending how your contract is looking. But nobody is clearing me that I receive money from the government and insurance companies. But think about that. Why does an insurance company give me money to run a trial of surgery versus non-surgical treatment? Because the insurance company and the Ministry of Health, they want to lower down the surgery practice. So that's also a conflict of interest. So that's the reason why I show this to you, and a little bit more elaborately. And the next thing I want to say before that, I was a little bit worried. And I was worried 2 years ago, and I don't think Atul is here. No, Atul. I already warned him yesterday, so maybe he's not here this morning. I loved his presentations, and I also loved the presentation of a lot of good doctors, also of Alan Crockett and of Boriani, but I want to see data. And if I hear something like the foramen magnum decompression is an historical approach, then I'm getting worried. Because why is it a historical approach? Why can't we do a posterior foramen magnum decompression? Why are we not allowed to do an anterior decompression and go for more expensive implant use? So if I use implants, I have to be sure that it is more effective than simple decompression. So that's the reason. I'm not worried about hearing this, but I'm worried that we are proceeding in the wrong direction. So I think that every new technique using implants, a new surgical technique, needs evidence before we go for reimbursement. That's a little bit harsh. So every new treatment, before it goes reimbursed, we need evidence for that. Maybe even the old treatments. The reason why is, for instance, this is my area. These are the hospitals which I'm leading the neurosurgical department. And it's not important how many surgeries are being done. This is the area. And some of the colleagues in my area are even friends of Sandeep, which he's now Epping, I think. But these are the implants we use. 3.1 million euro per year for spinal implants. Not about deep brain stimulation, not about drains. This is the cost. And the total cost, excluding the staff salary, is 5.2 million euros. That's 2 years ago. This area, The Hague, Leiden, and the northern part of Rotterdam, and Haarlem, this is the southern part of Amsterdam, is a very crowded area. So it's a crowded area where a lot of surgery are being done, but there's also a lot of practice variation. You just heard Doug talking about the Dartmouth map of practice variation. This area is crowded with spine surgeons, so it's crowded with spine surgeries. And we should be aware of that. So it's a marriage of healthcare and economists. And this guy is always Canada, if you talk about evidence-based medicine and economics. He was saying, well, something old, something new, something borrowed, something blue. And we have to be taking care of what health economists are thinking about our way of working, but we also have to understand them. So if you look at this the first time and you don't understand, you say, oh my God, what I'm looking at. But you have to understand it. So this is what health economists are saying. And this was published in the BMG a few years ago. In the BMG, this group, that at that moment, the Bush company, the leader of that, CEO of that was the health minister of the Netherlands. So after being health minister, he became the CEO of a commercial company, Bush company. They published this in the BMG. We as spine surgeons, being orthopedic or neurosurgeons, don't read the BMG regularly. Healthcare ministers, insurance companies do read it. And what did they say? They said, well, if I look at all the treatments surgically or medically being done, more than 50%, there's no evidence for that. I say, okay, because there's a lot of old treatments where we cannot find an RCT because it's regular for us. Well, they say, well, only this one is beneficial, so we should only reimburse this one. That's what they are thinking, not what I'm thinking, that's what they are thinking. This is likely to be ineffective. For spine surgery, that might be low back pain surgery without any abnormalities. That might be that part. This might be sciatica after 2 or 3 weeks. But this part, we don't know. Is that bad? Well, it might be bad because if you look at the Dutch system and the amount of billions of euros going on, this is what the surgery is expecting to pay in our country. And this is what is happening in our country. So this is the amount of money we do have, and this is the costs of healthcare. So if you are the Ministry of Health and you are standing before the spine surgery community, they say, well, we have to reduce the cost. No matter how, we have to reduce the cost because we cannot pay for treatment anymore. But I doubt that. So I don't believe the slide 2 times ago. I don't believe this one because these are part of treatments in which we cannot find good randomized evidence. So is that more than 50% of health costs ineffective treatment? No. And I explained it already 2-3 years ago to some ministries of health in Holland, in the UK, and in Germany. But last week, again, this message came in. And not from an insurance company, but from a medical doctor who was a little bit frustrated and said, well, more than 50% what those surgeons are doing is not evidence-based. So, if this kid comes in with a paraplegia or tetraplegia or tetraparesis, can we find evidence that what we did in this kid is good work? I think it was good work. This kid was happy that he was operated upon. He was neurologically very good recovery. But can we find evidence? Would somebody of you randomize this patient between surgery and wait and see? I think nobody would. You can discuss the sort of surgery. Maybe my surgery was a little bit too much or too less. That's about the technique. But if a patient comes in with neurological deficit and you do this and the patient is recovering, this kind of surgery is within this 50% without evidence-based medicine. There's no evidence for that. That's one side of the coin. Then the other side of the coin. This is what also is happening. And that's the reason why some of us don't have a good name in some countries. Scoliotic deformity, before surgery, after surgery, 80 years of age. So is this good medicine if the patient only has low back pain or have some sciatica? Well, if you look at that and you look at the same group of Dartmouth and the group of Rick Dio, they looked at the amount of surgeries in the United States in Medicare, and they looked at fusions for spinal stenosis. This is without any knowledge about the content. So there is no spine surgeon involved. But what they published, and most of you don't know this paper, what they published in the JAMA is that the risk of a complex fusion compared to simple decompression, which is standing here, risk of cardiopulmonary stroke complication or mortality is high. But it looks high, nearly 3 and 2.5, but it is an odds ratio compared to a very low risk. So you have to know that. But non-medical trained people say, well, that's too much. The costs are also too high. So that's the reason why we should have a little bit more looking at evidence-based medicine. And we all know the discussion about failed back surgery. Well, I think there's failed backs and not failed back surgery. You can have failed back surgery, but then we train the people not properly. So there is evidence of fusion against low back pain, but this is the amount of disc cell around the world after the FDA approved the intervertebral disc for PLIF and TLIF. And this is how Medtronic trains its people 10 to 15 years ago. Medtronic went to their people and said, well, you have to visit the spine surgeons, and you don't only want to sell them what kind of screw and what kind of rod, but you have to know that the hospital and the doctor earns money. So a doctor doing a fusion receives more money than doing decompression alone. That's in the United States at that moment. And the hospital also receives more money. In my country, it's the other way around. Spine surgery is not very good for your wallet. So it's better to have brain surgery in your department than spine surgery. So in my country, it's difficult to have spine surgery in your hospital. I'm very happy in Leiden and The Hague that they pay for our group, but in the United States it was the other way around. And this is the cell of western part of Europe of implants throughout western part of Europe. So spinal implants in the western part of Europe. Huge practice variation. The red spots are high rate of surgeries. And the lighter, the lower amount of surgeries. So the Netherlands is in between. I don't see Turkey because we didn't have numbers of that, but the Netherlands is the same sort of people like Belgium and in Germany. So we cannot explain this, why we use more spine implants in Belgium. We can explain Switzerland and Austria because of the skiing. So more trauma, more spine implants. But we cannot explain this. And we should explain that. So that's important to know. Then one step back. What do we want to have a new treatment? A new treatment wants to look at the cost effectiveness plane. So it should be more effective, and if it's more effective, it might be more costly. If it is less costly, the new treatment dominates. But we also say if it's more costly, then we can also discuss that. If it is less effective and more costly, then the existing treatment dominates. But what is effectiveness? And what is quality? You're talking about qualities, and we have to do research looking at outcomes. I'm doing a lot of research. I'm looking at qualities, but I don't understand it. So how can I explain to my patient coming into the physician assistant, not the surgeon, what's the quality? I cannot explain that. But health economists are talking about qualities like it's their daily life. Well, one quality is 1 year in complete health. So 1 year in a complete health without any disease, without any socio-economic difficulties. So it's used for ICR, and you can use it, and then you can say, well, the new treatment is dominant, or it's a trade-off. And what is the trade-off? The new treatment is more effective, and in the Netherlands, it might not cost more than 100,000 euros per quali. That's interesting. So 100,000 euros per quali. I asked the Ministry of Health, what is this quali? Well, you know that because you're a researcher. Okay, not discuss spine surgery, brain trauma. Your kid comes in, 20 years of age, brain trauma. Do I have to treat that? Yes or no? Yes, you have to treat that because it's life-threatening disease. What's the cost per quality for a brain trauma treatment? Well, if brain trauma treatment survive severe brain trauma, the cost per quality is 250,000 euros per quality in the Netherlands. And we are now looking at Europe. So should we stop doing that? Nobody's discussing that, but this discussion is fine. So they want to look at effectiveness, these kinds of surgeries. This is sciatica surgery, early surgery versus wait and see. Early surgery is more effective, wait and see, 40% delayed surgery. It is more effective. If you look at health economics, there's a difference in favor of surgery. So qualities are raising quickly, but it's a small difference. And the difference is only 0.04 quality. And I say it's too small. And health economics is saying, well, Wilco, 0.04 quality, it is statistically significant. It is a small difference, but it's okay. I said, no, it's not okay. He said, well, 0.04 quality is 2 weeks in a dead state per year. And I want to be 2 weeks at the Bahamas in full health. So end of discussion. So in the end, and I will stop quickly, in the end, it's more cost effective to do early surgery